Thank you, Mr. Chairman. And at the outset, I'd like to thank the organizers, the INAZL Secretariat, Dr. Duseja and others for giving me this opportunity. As the third speaker in the series, I hope there's not too much overlap between what I have to say and what has been said, but I'll try and minimize that. I've been asked to talk about predicting HCV after the eradication, HCC in patients after eradication of hepatitis C. So briefly, although this may be a bit of a repetition, I'd like to first mention about the burden and the importance of HCC and why we must do surveillance for HCC. Currently, almost 1,854,000 new cases are diagnosed every year, and with the very high case fatality ratio, it is currently, at least because the advanced stage disease is picked up, diagnosis often means a death sentence for the person. And it is projected that the burden of HCC is going to increase significantly over the next 2 decades. The burden in Europe is about 1/10 of this disease burden, and as you can see, the cost of managing HCC is quite high, estimated at 4 billion euros every year. Surveillance has been going on for several decades now, but it hasn't really yielded the results that were expected from a program and when we institute surveillance. And a study from the UK points out why this is, that even while surveillance is going on, there is actually an increase in the incidence and mortality due to the disease. And fewer than 1 in 5 of those who are eligible for curative treatment in the UK actually receive it, even once surveillance is successful and they are picked up. In India, the HCC burden and the information is rather scanty and scattered, but it is estimated that something like about 34,000 deaths due to HCC are happening every year, and this number is bound to go up. Now, we know about screening and surveillance. Screening is a one-time effort at identifying asymptomatic patients at an early stage of disease, while when you do this thing repetitively over a period of time, then you will have this population under surveillance to pick up the disease, in this case HCC. And the basis of surveillance is that effective curative therapy is available if we do happen to achieve the goal of surveillance, that is pick up disease at an early stage. In fact, all current guidelines do recommend surveillance for HCC, and the standard technique, that is the standard approved method, is that of using 6-monthly ultrasound and alpha fetoprotein measurements. And the major problems with the current strategies in surveillance is that there is poor awareness at the level of the physician and the patient. There is poor adherence to the advice that is given often for regular surveillance, and often in parts of the world where surveillance is most needed, access to the tools of surveillance is very limited, and the net result is we really do not have a very effective surveillance program for this condition. In hepatitis C, we know very well that there is a natural history and progression to the development of HCC, which takes place over a period of up to about 25 years. And ever since we have had DAs over the last 10 years, cure rates for hepatitis C have significantly gone up, so that patients with advanced fibrosis and cirrhosis are living longer. And even though the hepatitis virus may have been eliminated, the cancer risk remains. And this has been estimated at roughly about 4% per annum in patients who are not treated, according to historical data, which, following the development of SVR, following the use of directly acting antiviral drugs, has come down to about between 2 to 2.5% per annum. And according to the EASL and other international guidelines, the threshold above which surveillance should be offered to patients is when the HCC risk is more than 1.5% per 100 patient years of follow-up. And a more recent study suggests that the cost effectiveness threshold for HCC surveillance would be once the risk of HCC has crossed 1.32% per 100 patient years. So currently, for chronic liver disease, what we usually follow is that if the patient has a poor liver function and is awaiting a liver transplant, then you would not be screening these people regularly except in certain programs. But if they are not transplant candidates, as many parts of the world, then they should be offered biannual screening. while those with advanced fibrosis and where the etiology advanced fibrosis is not present, example in MASLD and in HCC, in HBV infections, then we can have biannual surveillance, or in certain subsets of patients there may be no surveillance offered, and that is the way currently most surveillance programs are running. But now, as would have been apparent from the previous talks, the way we have to go about surveilling our patients in future is identifying prognostic factors, developing mathematical formula that tell us individualized HCC risk for the person, and then following a decision rule, you eventually implement an optimal surveillance regimen. And as was emphasized by the previous speaker, the emphasis now is more on identifying those at very low risk of developing HCC who may not, on whom resources for surveillance may not need to be invested. So who should undergo surveillance according to current guidelines are those who have an annual risk of HCC in excess of 1.5% per annum, and with the currently available tools this works, and this includes patients with liver cirrhosis, child's A and B. Non-cirrhotic patients also are included in this, especially those who have active hepatitis, a family history of HCC, and when they belong to particular ethnicities. In chronic hepatitis, those with advanced fibrosis following SVR remain candidates for development of HCC, and they should be included in screening programs. And these are the current recommendations. And again, it's important to remember that screening should be reserved for patients who, in case you do identify early disease, are candidates for various interventions that are currently available for HCC. So those whom we should not be recommending for screening are those with cirrhosis and advanced stages of liver disease. Occasionally in some programs, those on waitlisted do get screened even though they have advanced disease. Whereas those with inactive HBV infection, screening is not recommended. And similarly in NAFLD-NASH who do not have cirrhosis, current guidelines do not recommend screening in them, and we already talked about their poor performance status. Now, what can be the strategies to improve HCC surveillance? And a recent publication from the EASL talked about moving towards a policy of risk-based surveillance for HCC in patients with or without cirrhosis. And what you basically mean is that we need to stratify the target population that is at risk as per the previous slides that I've shown you, and stratify them into cutoff thresholds, identify a high-risk group who are likely to develop HCC and eventually die of this HCC. So this generally constitutes about 1/5 of the population being surveilled, whereas the low-risk group who often have concomitant diseases, concomitant risks due to advanced liver disease and other comorbidities, who may actually, even though a tumor is picked up, they probably will not die of the tumor, rather they will die with the tumor, and they may not need surveillance. This constitutes about 10% of the target population. And by identifying these high-risk groups, limited resources can then be focused on these groups using more advanced ways of surveillance. So this is the modeling that they did, that 10% once we stratify them may not need surveillance. 20% may need MRI, limited MRI and other more advanced tools for screening, while in the other 70% one may continue with the standard surveillance protocols. So now coming to the risk-based surveillance models that we have for chronic hepatitis C, a large variety of them have been identified, and the intention here is to stratify HCC risk, thus decide the level of surveillance. The commonly used ones are the Toronto HCC Risk Index that was proposed in 2017 using the parameters of age, etiology, gender and platelets. And this was validated in patients with, apart from HCV, also had other comorbidities, and eventually the high, medium and low risk strata were established, which I'll show in the subsequent slides. Similarly, the AMAP HCC risk score, which talks about age, the male gender, albumin, bilirubin and platelets, in a very large cohort of over 17,500 patients, including a significant number with the chronic hepatitis C, was validated and risk strata were established. The Veterans Health Administration model used a very large number, over 45,000 patients in whom, using the parameters of age, AST-ALT ratio, platelets and albumin, risk stratification was done according to cirrhosis present or absent and SVR achieved or not, since it included a historical cohort in which interferon therapy was used and SVR rates were rather lower. And this was predominantly in the genotype 1 that is seen in North America. Subsequent studies, which I'll be talking about now, have been focusing more on using non-invasive tests and identifying the low-risk group of HCC. This study from Spain, Barcelona group, Hepatology 2020, used the liver stiffness or FIB4 along with albumin and delta LSM change over a period of time, over a period of 1 year, in patients with compensated advanced fibrosis, and came out with their risk scores. Similarly, genetic risk scores have been proposed for some patients with HCC, but mainly in the ALD, NAFLD population, and the male gender, diabetes, albumin, and the genetic risk score, in which scoring was done for the various polymorphisms of gene that are associated with the hepatic steatosis that are shown here, was carried out. And again, as I mentioned earlier, the intention now seems to be, rather than simply identifying people at high risk for HCC, which is a small group, and it's fairly apparent from those who have significant portal hypertension, who have more advanced or decompensated liver disease. The surveillance strategies are now focusing on more on identifying those who have a lower risk and who may actually not be candidates for close surveillance. And the thresholds I've already spoken in an earlier slide. The thresholds above which you would like to include surveillance become important in this context. The other important score that we have used for HCC in hepatitis C has been the Toronto HCC Risk Index, which was again derived from over 2,100 patients, including patients with hepatitis C cirrhosis, using age, etiology, gender, and platelets, each of which were given scores, so that overall the score ranged between 0 to 366. And cutoff values for low, intermediate, and high risk were established, with a low score of less than 120 corresponding to a 0.3% HCC risk, whereas the high risk with a cutoff of a score of 240 or above, according to this scoring system, implied a HCC risk of over 3.2%. And when this was validated in an external cohort, fairly high concordance and the C-stat, about 0.71 and 0.73, were obtained in this using this risk index. Last few minutes. The AMAP score that we have talked about in the large number of patients. Here again, the cutoffs that were identified using age, male gender, albumin, bilirubin scores, and platelets were between 50 to 60, and more than 60. And with these, although this score needed external validation and competing risk analysis, it was fairly good at identifying low, medium, and high risk and stratifying patients accordingly. Now, as I was talking about the need for looking at this in post-SVR cirrhosis, so in a cohort of about 500 patients who had advanced fibrosis as picked up by LSM values or histology, and the HCC risk over a period of follow-up of 4 years was found to be 5.9%, and based on this risk prediction models, either including age, albumin, and LSM, or albumin and the FIB4, because LSM may not be available universally, they were able to establish scores for these parameters and a cutoff of about 83 points for the score using LSM, and a cutoff of about 48 points for the score not using LSM. Nomograms were again laid down by this group, so that looking at any value given for these parameters, the corresponding point score could be calculated. And using this, they actually found that they could identify the low risk group that they pointed out below 83 points had only a 0.16% or a 0.25% risk of HCC, which was well below the screening threshold that was suggested. On similar lines, a German group has recently published a study in which validation was done in patients with post-SVR HCV with compensated advanced chronic liver disease as picked up by an LSM value above 10, HVPG about more than 6, this is the last slides, and or biopsy related fibrosis being picked up. And using these parameters, age, albumin, liver stiffness measurement, and the AFP and alcohol values, what you could establish was that low risk groups, which amounted to 71% and had an HCC risk of only 0.9, could readily be identified. And this study was also validated in an external cohort, while the other score gave similar high discrimination values. So that using these stratifications in almost 2/3 to 70% of patients with compensated advanced chronic liver disease, which is our main target group for surveillance, you could identify those who probably did not need surveillance. A recent study has compared the various 4 non-genetic and 2 genetic risk score factors for predicting and how well they perform in 2 independent cohorts, the Scottish and the STOP HV cohort. And what they found here was that the AMAP score actually gave the best C index in both cohorts, followed by the VHA and the THRI, that is the Toronto Hepatitis Risk Score. And it is now being said that the AMAP should be considered as the benchmark for screening patients with compensated advanced chronic liver disease. So, I think we've covered much of this. What I'd say in conclusion, what we are finding is that there have been rapid advances in our approaches to screening the patients with HCV over the last decade, and we are moving to a risk-based surveillance approach in which prediction, individualized and personalized risk scores for individuals may be predicted. And apart from identifying a high risk who need intensive surveillance, it's also important to identify the low risk group who may not need surveillance, and thus we may be able to achieve our target of detecting early to treat cancers and trying to treat and cure HCC at an early stage. Thank you.